Hello. Today I would like to explore the idea of mental illness as a hypothetical construct. In clinical psychology training, clinical psychologists will be the first to tell you in any kind of diagnosis and classification coursework that mental disorders such as depression, schizophrenia, generalized anxiety disorder, borderline personality disorder, intellectual disability, anything like that, post-traumatic stress disorder, social anxiety disorder, the list goes on and on, major depression, schizoaffective disorder, avoidant personality disorder, that any of these disorders are hypothetical constructs. But what is a hypothetical construct, you may ask? That's a bunch of weird words, right? Okay, a construct in the philosophy of science is an ideal object where the existence of the thing may be said to depend upon a subject's mind. This as opposed to a real object where existence does not seem to depend on the existence of a mind. So, this is an object. This is a book filled with constructs where the existence of the things contained in these pages, so eating disorder, pica, that's where it flips right here, is the existence of these things depends upon the subject's mind, a person's mind, okay? Mind gives rise to these things. In a scientific theory, particularly within psychology, a hypothetical construct is an explanatory variable which is not directly observable. Okay? These are things that humans have created to better understand reality, to describe phenomena that are being observed. We create these categories that explain these patterns of behavior in the context of mental illnesses, okay? So again, these do not exist in nature, but they depend on the belief in the disorder, okay? So intelligence, motivation, not directly observable. However, we can directly observe symptoms. So a person's heart beating rapidly or a blood pressure increase. These are interpreted as signs of anxiety, evidence that an individual is experiencing anxiety. And self-reported anxiety, self-reported depression, self-reported various symptoms that we then relegate and put into categories that are in this book that are intended or are used to conceptualize a given person and to guide treatment decisions in the treatment of the symptoms which constitute the mental disorder description or perspective. And the DSM is the first to admit that these disorders, these mental illnesses, were created to facilitate communication amongst psychologists, psychiatrists, health practitioners. Okay, these were not designed in the service of the people. Okay, they were designed in the service of the paradigm of psychology, the framework, the perspective of psychology, which again is a discipline of hypothetical constructs which need a person's mind, need people to believe in it in order for it to truly exist. So, again, the DSM, psychological diagnoses at large, were created to facilitate communication between practitioners, to allow health professionals to quickly talk about people in a reductionistic fashion, in a more simplistic fashion to facilitate quicker, more concise communication. Now, this is great, right? We can talk about a person in fewer words, but you're missing a lot. You're missing the complexity within each individual. You're failing to treat an individual as a whole, taking into account the entire picture, and you're reducing an individual into component parts that are organized in such a way that we're pathologizing or calling pathological, calling maladaptive, judging. It is a judgment that a person is not functioning according to society's standards, to a culture's standards, to standards which again are social constructions. So this gets really interesting as you break it down further and further. So in the DSM-5, the section in the introduction, A Brief History, the APA first published a predecessor of the DSM in 1844 as a statistical classification of institutionalized mental patients. It was designed to improve communication about the types of patients cared for in these hospitals. This forerunner to the DSM also was used as a component of the full U.S. Census. After World War II, the DSM evolved through 4 major additions into a diagnostic classification system for psychiatrists, other physicians, and other mental health professionals that described the essential features of the full range of mental disorders. It provides guidelines for diagnoses that can inform treatment and management decisions. That's straight from the book. So I invite you to question the idea of mental illness in doctorate clinical psychology training programs, of which I have been a student the past 2 years. Again, we learn that these are hypothetical constructs. They do not exist as things in themselves, as Kant would say. But then for the next years of training and in professional practice, I would assume, in research, I would also assume, that these are treated as things. They are treated as labels. They are used again and again. And we sit around pretending that these things exist. And there's nothing wrong with that, right? If it's not producing harm, if it's not causing harm, that's okay. But I think in many cases, this pretense causes a great deal of harm. And again, I would invite you to really think about and reflect on what is mental illness, and is this concept benefiting society, the individual, the world at large, or is it not? There is no right or wrong answer. This is just an idea to play around with that does affect people of all backgrounds, in all walks of life. So I invite you to think critically about mental illness. Thanks for watching.